Myself, and one of the things that I have noticed since I've been in practice is that I have a lot of patients who are runners as well. And inevitably they all come to me and say, I pronate, I supinate, and the majority of the time what they're telling me isn't correct. So what I'd like to go through, because I always watch them walk, because there's always in run, is a little bit about biomechanics right off the bat so that we're all kind of on the same terminology of things, and then we'll go into a little bit of the pathology as well. If there's any questions, we'll take those as well. So a little bit of an overview, some anatomy, a little bit of biomechanics, some common injuries, and then hot topic right now obviously is barefoot running. I'll try to touch on that at the very end. So the foot and ankle is a very complex structure. There's 26 bones, 33 joints. There's more than 100 combination of muscles, tendons, and ligaments. Okay? On the inside portion of your foot, you have muscles that are involved in basically holding the arch of your foot up, okay? And we'll go into a little bit more detail in that area. On the outside portion of your foot, you have ligaments and tendons that keep your ankle stable and evert your foot. And basically the whole structure of the foot is made so that it's stable, okay? You have multiple bones that come together that form an arch. And that arch is what makes your foot stable. You don't have one bone that looks like an arch, you have multiple bones that all come together, and each bone is important for holding up the whole foot and making it stable. So if any one of those bones becomes injured, then it becomes a problem because all of them are intertwined in keeping your foot into a stable platform, especially as you run, where you're getting a lot of force. I'm going to go through this. It's going to take a little bit of time because I think this is something that's important to understand when it comes to biomechanics. This side right here would be the inside portion of your ankle, the medial aspect, so that would be here. And this side right here would be the outside portion here of your ankle, okay? You have a joint below the ankle called the subtalar joint. The talus is the bone in the ankle that bends up and down, but it's also one of the bones that bends side to side, okay? So this joint is called the subtalar, below the talus joint. It has two axes, but the majority of the motion is done on one axis. And basically the motion is inversion and eversion, side to side motion, okay? And a lot of the force as a runner that your body goes through when it comes to the foot is involved in these motions. So if we draw a line here, right through the ankle, this is the talus bone, and again, this is the inside portion, this is the outside portion. The majority of the motion is going to be on that axis. So if that's my axis, I'm rotating like this, okay? So what does this cross-sectional view, basically straight through the ankle, show you? These are the tendons that are on the inside portion of the ankle. These are the tendons on the outside portion of your ankle. Anything on this side is going to be responsible for keeping medial stable or inverting your foot, moving it like so, holding up the arch of your foot, okay? Posterior tibial tendon would be the major inverter of your foot, okay? On the outside, you have the peroneal tendons, the majority of what are involved in everting the foot, or flattening your foot out, or pronating, okay? And so what I want you to understand is that there is a very, very careful balance between all of these tendons and muscles to keep your foot stable. And the minute that one of them isn't functioning, then you run into an imbalance. Like the posterior tibial tendon, if you have a weak peroneus brevis tendon, can take over, and some people develop what's called a varus or equinus foot. Or if your tibialis posterior tendon becomes ruptured or torn, you develop a flat foot because you're not getting that support along the inside portion. So I think that if you go into kind of understanding just grossly that, you really understand a lot of biomechanics right now because it's just the inner working of that axis and everything on the sides of it, okay? And so if you look at the ankle joint, and this is just simplifying things again, if you take your two fingers on the bumps on the outside portion of your ankle, the lateral malleolus, which is portion of the fibula, and the medial malleolus, which is a portion of the tibia bone, and you put your two fingers side to side there, that's basically the axis that the ankle joint moves. It's kind of almost like a hinge joint, okay? So if we draw that line, and again, medial is the inside portion, and lateral is the outside portion, we see that anything in front, anterior, would be dorsiflexors of the ankle. They bend your ankle up. And anything in the back are plantar flexors. Strongest dorsiflexor is the tibialis anterior tendon. Okay, if someone develops tibialis anterior tendon rupture, or if they have some sort of nerve injury where they lose the ability to function that, then they develop a drop foot. Okay, And then in the back part of their ankle, the Achilles tendon is the strongest, attached to the calf muscles is the strongest plantar flexor. Okay, that's what we use when we go up on our toes, the strongest muscle in that area. So when you look at running, and in particular I'm going to talk about running with shoes on for right now because that's what most people do, although some don't. You can understand running basically where most of the force is kind of translated is at heel strike. Okay, so you've got a patient who's an underpronator or has a high arched foot, a normal foot, and someone who's overpronator or more of a flat foot. What you can see is about at heel strike, they're all about the same. Okay, it's not necessarily the heel strike where their heel hits the ground that's different. It's what happens afterwards. All right, you should pronate or pronate somewhat when your heel hits the ground because that's how your body absorbs the shock. If you have a high arched foot, you don't pronate hardly at all, and your foot stays almost into the same position it was in, and you get much more force going up through your leg. Okay, and even when you go off on your foot, you're still on the outside portion of the foot. This is a person who has a flat foot or overpronates, and when they go through transitioning from the heel strike, they over accentuate the pronation that should normally occur, and they start to strain the inside portion of their ankle and foot, whereas this type of a person would strain more the outside portion of their foot because there's more force on it. And then obviously in normal or neutral, that is pretty even all the way throughout. Okay, so just in general, looking at different types of foot, one thing to try is always when you're getting out of the shower, you can look at your footprint, or you can take a piece of paper when your foot's wet and stand on it and see what you look like here. But in general, a normal arch would be just about like this. The heel, when you look at it from the back, somebody looks at you from the back, would be pretty much straight in line with the rest of your leg. All right. Someone who has a high arched foot has usually what's called a varus position of the heel, where the heel tilts out. Okay. And so when you looked at this picture, you can see how they stay on the outside portion of their heel as they load through on the foot and keep more pressure onto that area. Versus, and even when they stand, there's not much contact in the whole mid portion, the arch of their foot when they're standing in a very high arch. A flat foot, obviously, someone who doesn't have much of an arch. Their heel, if you look at it, instead of going out like this, rotates in. Okay, we call that valgus. And obviously, that, like Dr. Williams talked about, we'll talk about a little bit later, it can cause abnormal stresses all the way up to the knee. So the patient who overpronates, they're loading much more medially, and then even throughout toe off. You can see one of the things that I notice when people run, and particularly some people really flare out with their foot or abduct. Most of the time when they do that, they have very tight calf muscles and they have a flat foot. Okay, so if you run like that, there may be a reason for it. So again, this is the type of foot. Supinator would be an underpronator, or a person who has a high arched foot. Neutral, that's what would ideally be the best, and someone who has a flat foot or pronates. One thing that you can look at is obviously look at your shoes and see how you wear them. That can say a lot about how a person runs or even how they walk. If you look at this diagram, someone who has more neutral would wear kind of on the red here. Everybody loads the lateral aspect of their heel at heel strike. It's what happens right after that is mostly different. They go a little bit more neutral throughout the portion of the foot there. Someone who pronates or has a flat foot is going to start loading more medially and then all the way through toe strike or toe off much more medially. And oftentimes these people, a good portion of them, have problems with bunions and things because of it pushing their great toe into a valgus or lateral position. And a person who's an underpronator or a high arched foot is loading laterally or on the outside throughout. These are the people that get problems with pain on the outside of the foot. They can get stress fractures of the fifth metatarsal. They can have problems with ankles giving out on them just because of how they hit the ground and how they walk. So if you look at gait, and this is just a walking gait, it's kind of divided into two different phases, a stance phase and a swing phase. We start off in stance phase when the heel hits the ground, and then we go forward to toe off, and then it ends when the other heel hits the ground, okay? So to show you a little bit about what a normal gait would look like, this is heel strike. Heel is in a slight, what's called just a slightly inverted position if we're referencing the back of the leg here. and the heel, it's slightly inverted, okay? That means it's slightly tilted out, that's normal. And then as we go to mid stance, where the heel hits, where your foot goes flat onto the ground, the heel does pronate or go into valgus slightly so that your body can absorb stress and shock. And then when you go up on your toes again, your heel goes pretty much neutral, okay? Neutral to the lower leg. And then on toe off, you're in varus again, because your foot forms a rigid lever to move forward, okay? And it's the differences in these that can cause problems because of what we talked about. The tendons on the outside and the tendons on the inside can be strained if there's not a perfect balance between all of those things. And all those things can be accentuated with running, okay? So I just showed you what happens when you walk. Now let's go through what happens when you run. When you're running, sometimes when people do a slow jog, it's different than this, but typically someone who's running, only have one foot on the ground at a time, and there's a period of time where both of your feet are off the ground, okay? So that, what does that basically equate to? Well, it basically means that there's going to be more force because you're spending more time on one leg and not transferring to the other, as well as your stride length increases, so the amount of force at the heel strike is increased as well. And then because there's a period of time when both of the feet are off the ground, when you do land and descend at heel strike, there's more force as well. The double swing phase or float phase, a period of time when both of the feet are off the ground. So the moral of the story there is just the increased amount of weight that your body takes from running because of the fact that the stride length increases, as well as the fact that both feet are off the ground for a period of time, and then you land on one foot with 2.5 to 3 times your body weight. This is just a pressure mapping scale where they took patients at the contact portion of gait there running, and at the 0.08 seconds, majority of the pressure's on the heel. Then at 0.32, it goes to the forefoot. So there's a quick transition from the heel to the forefoot, and the majority of the pressure is sustained in a normal running pattern to those areas, okay? So you can see that if you look at this diagram, which is basically a graph that goes up and down showing you the force of the body weight as you run, the highest force is right after your heel hits the ground. So you have some force as the heel hits the ground, but then the body absorbs it and it goes up a little bit more, and then comes back until the point where your foot is getting right ready to the heel to lift off the ground. And right before the heel lifts off the ground, you have more force as well because the whole body is contacting the ground. So that's a little bit about biomechanics, and I do that to set up some of these things I'm going to talk about in terms of running problems and injuries. 20% of runners, 20% of running injuries involve the foot. Okay, so it's a pretty high number. You can have I kind of break it down into different areas. Forefoot, which is generally pain in the ball of your foot, can involve bunions, hammer toes, metatarsalgia, which is just a kind of a term for a plethora of things that can happen. Stress fractures, hind foot. Number one thing that we would see in runners are plantar fasciitis. In the ankle, peroneal tendon or posterior tibial tendinitis and ankle instability, amongst a few other things. Those are the more common. And then shin splints. So just kind of a touch base on this. Some people have congenital deformities or slight bony prominence on the inside portion of their great toe joint called a bunion. They can have one on the outside portion of the foot called a Taylor's bunion. You can have hammer toes that are cocked up like this. In and of itself, that does not preclude you to run. It just means that you have to make sure that you have shoes that accommodate for that. For a runner, the biggest problem would be this being tied up against your shoe. So I've seen plenty of people who have these types of things and they still run marathons. You just have to make sure that you accommodate it. And the best way to accommodate it for is to make sure, like right here you see the shoes rubbing up against that area. You would want to make sure that your shoe has a wider toe box, or if you have a bunion, you may need a wider shoe to wear that, okay? Corns and calluses, basically response to pressure. And a common area I see these is in between the 4th and 5th toes. Some people will have like a 5th toe that's somewhat curled and it'll underride the 4th toe. Well, the bones from the 2 toes begin to rub up against each other, especially if the shoes are tight or if they do a lot of activity like running, and they can get a real painful corn in between there. Sometimes it benefits if they have that slightly trimmed out, or wear a little pad, silicone type pad in between that. If it comes to it, there's a very simple surgical procedure that can be done to correct that if needed. Also on the bottom of your foot, if you have any sort of a bony prominence, it can lead to developing corns on the bottom as well. accommodation is probably the best treatment if you can do that. Soft, tight pads, having them trimmed down periodically. Pain in the ball of the foot, metatarsalgia is just a term you're describing pain in the ball part of your foot. There's a lot of different things that cause it. We'll talk a little bit about that, but generally it's just a term for pain in the front part of the ball of your foot. The other thing that's very common people get in that same area, in between the third and fourth toes, the ball of the foot shooting to the toes would be what's called a Morton's neuroma, and that can be aggravated by running, I know, because I have one of those myself. So, but there are simple things that can be done in terms of different types of padding and some other things. One of the big problems with pain in the front part of your foot is having tight calf muscles, okay? The gastroc and the soleus are the major, they're attached to the Achilles tendon, and when I showed you the biomechanics at the beginning, they're the major plantar flexors, or bending down at your ankle. And because of that, if they're very, very tight, when you run, when you walk, they put an increased amount of force, because your ankle, like I said, is like a hinge, they put an increased amount of force right onto the ball of your foot. So if you have any sort of, a deformity to begin with, like you may have a long second toe or a bony prominence on the ball of your foot, if you have a very tight calf muscle, it'll make it worse because you're going to put more pressure into that area. So usually forefoot pain and problems, one of the very first thing I recommend is stretching that out. And I'll show you some stretches that you can do, okay? There are different types of pads that you can put into the area. You can find that basically at any drugstore. And then, ultimately sometimes runners need orthotics for their shoes that help to evenly distribute the weight on the bottom of their foot. And then sometimes a pad called a metatarsal pad can help lift these bones up. Or if it's a neuroma, it can help spread the two bones apart that are impinging upon this nerve and can help with pain, okay? So here's some general stretches, and these are things that you can find on the internet, just general stretches. But I would tell you that one of the important things is to stretch not only your gastroc but also your soleus muscle. Okay, and the way that you do that is basically that this is the old runner stretch where you lean forward, keeping your heel on the ground, and the one leg in front of the other, with the leg in front having the knee slightly bent. And when you lean forward, you should feel a slight stretch right in the back of your calf. Okay, when you do that, you're stretching your gastroc muscle, which is the stronger muscle. More important one to stretch, usually the one that's usually tight, but it's also important to stretch your soleus. And how you stretch your soleus is that simply put, the gastroc starts from above the knee. So if you bend your knee, you relax the gastroc. The soleus starts from below the knee. So if you do the same stretch with the knee bent, then you're stretching the soleus. Okay, you're not going to feel as much of a stretch, but you should still feel something. And those are good stretches to do whether or not you have problems, because one of the major things that causes problems in the foot and ankle are tight calf muscles, or what's called an equinus deformity. Dr. Williams talked very well about stress fractures. I won't go through the pathophysiology other than runners are at high risk for what are called metatarsal stress fractures. And what I'd like to do today is just kind of reference you to some of the symptoms, because if you do have this, then the only way to get it to kind of calm down is rest. Typically the pain is not in the ball of your foot, it's just proximal to that, almost right into this area that's circled on this picture. Drew out one of the metatarsal bones, and usually it's right about there. You may have swelling to the area, you definitely have soreness, it's usually palpable. At times, if it gets bad, you can feel some swelling right locally to the area where the stress fracture begins. Typical characteristic things would be, it's pain that doesn't really get better, okay? Musculoskeletal pain that is better with rest, maybe a day or two of rest. This generally doesn't have that. It's something that's more constant, and then it's being re-aggravated by activities. Okay, it's not going away, and then usually it can progress from just bothering you while you're running to starting to bother you even when you're walking, and then we get concerned because this stress fracture, which is just a small weakening of the bone, turn into frank fracture and may potentially need surgery if the fracture displaces. So out of the things that I'm talking about, this is probably one of the more, especially as you get into your higher mileage, that people would be a little bit more at risk for. If you've ever had a stress fracture before, anywhere in your body, you're at the highest risk for stress fractures. So the way that you treat this is like Dr. Williams says, stop sign, rest. Sometimes we have to put you in a walking cast, and then the big thing is trying to figure out what caused it. Is it a biomechanical issue, tight calf muscles? Is there something else going on with the foot? Sometimes there could be a metabolic reason why people are getting these types of things. Very common thing too, number one thing I see in my office, plantar fasciitis. Okay, how many people have had plantar fasciitis? Okay, so a lot of people have had it. Characteristically, pain in the bottom of the heel, although that's not always the way that it is, but usually it is. Sometimes it can go up through the arch. People will describe pain when they get out of bed in the morning, and they walk around for a little while, it eases up a little bit. If they're standing for extended periods of time, it bothers them, those types of things. Okay. I like to show this picture. This is what I always give my patients because I like to show them that when I look at MRIs, it's quite amazing that the Achilles tendon, which is a separate structure, is actually, through soft tissue, attached to the plantar fascia through the back of the heel. And sometimes when I have to do surgeries to resect heel spurs, and you're dissecting that area, you can see that there's a soft tissue that connects the two areas. The reason I tell you that is because the number one way you treat this is to stretch out the Achilles tendon, okay? I can't emphasize that enough. That's the number one treatment. Now, there are other things you can do other than those stretches. You can use something called a night splint that often helps, especially if people have pain when they get out of bed in the morning. Keeps your ankle stretched the whole time that you have it on while you're sleeping. And then this is right out of my handout that I give my patients, SIPS. Something easy to remember because 98 to 99% of people with plantar fasciitis get better. It's just a matter of doing the homework, stuff you got to do on your own, okay? So I say SIPS because it's easy to remember, but stretching, icing, pills would be anti-inflammatories because one of the reasons people have pain at the beginning is because they get inflammation, so like your ibuprofens and those types of medicines, and then support, okay? Because biomechanics has a reason to play on this as well. Stretches are important. There's some belief that if you stretch some of the muscles inside your foot that we typically don't use because we all wear shoes, this may help support your arch more. So if you do some strengthening exercises with the toes by trying to grab a towel, you can do a specific stretch right for the plantar fascia where you try to bend the toes up, and you should feel stretching right into the arch. Calf stretch where you kind of drop it down in the heel, and then the soleus and the gastroc stretch we just talked about. This is very beneficial, taking an ice bottle and rolling it on your arch to help with inflammation, also stretch out the area. So, and support. If you have a deformity of your foot, like a very flat foot, like the majority of people who develop plantar fasciitis, although you can have a high arch foot as well, making sure you get the right support. Okay. A little bit about posterior tibial tendinitis. I show this picture just because I show you where people generally get pain associated with this. Usually you have a flat foot and you get pain on the inside portion of your ankle going down into the arch. Oftentimes it can be swollen. Usually if runners get it, it's not significant to the point where they can't walk, but it usually becomes sore and aggravated with activities. And there's usually some very simple things with the type of shoe and maybe an insert in their shoe or an orthotic that we can do to make that better. Ankle sprains. Some people may have had histories of ankle sprains, or a lot of times I've had this happen myself when I've been running. The ankle just gives out on you as you run it, and you may be able to keep running afterwards, might not. But oftentimes, if people come in to see me, one of the things I look at is their foot. If they have a high arched foot, they may have, just because of the way that their heel tilts out, maybe at when they're on uneven surfaces, at a risk for it just giving out like that. Okay. If it's a typical ankle sprain and you're able to bear weight right afterwards, generally activity is okay. I mean, you ice it down, you take your anti-inflammatories. But if it's a more severe ankle sprain and you're unable to bear weight, then I generally recommend you get it evaluated and get x-rays of it. But a lot of times, especially in the bad weather when people are running, they'll slip and have small ankle sprains like that. We'll touch a little bit about Achilles tendinitis. Again, the calf muscle, which is the gastroc and the soleus, come together to form the Achilles tendon and attaches back onto the heel. The number one reason people get Achilles tendinitis is tightness in that muscle, and it causes an increased amount of pull onto the back of the heel, and it can cause pain in the back of the heel, or it can cause pain right into the tendon itself. The more concerning pain would be pain right into the tendon itself, especially in someone who's a little bit older, because sometimes that can be the early signs of the tendon fatiguing and going on to rupture. Characteristically, Achilles tendon ruptures in this area, from what I've seen, are weekend warriors. 40-year-old guy goes up to play basketball with his son and takes a jump shot, lands, and blows that Achilles tendon, and then you have to surgically repair it. So one of the things that's important when it comes to Achilles tendon is appropriately warming up and doing your stretching so that you don't overly fatigue that and you don't cause a lot of strain, because if it's very tight and if you have any degenerative changes to begin with there, it'll be made worse. Sometimes people have little spurs or burses in the back of the heel. For runners in particular, this becomes irritating because it can rub up against your shoe repetitively. Oftentimes you'll see people who wear shoes who have this, and they'll have actually worn a hole right onto that side or in the back where they have the bump. In and of itself, if it's not painful, it's not a big problem, but again, it can lead to more severe degenerative changes to the Achilles tendon. Talk a little bit about shin splints, and that's just kind of a generic term. Shin splints does include possibility of getting a tibial stress fracture, so that's one thing that you always want to rule out. Way I usually rule it out is, like Dr. Williams said, focal intense pain needs you to be somewhat concerned about. And then also you always get a standard x-ray to make sure that you don't see anything. X-rays don't always show stress fractures right away. But characteristically, people who have shin splints will describe it more as, they run, they develop this. As it gets more severe, it'll start to bother them even after they're done running, but then it'll go away. They don't have pain when they're walking. If it starts to progress when they're developing pain, even just when they're doing their normal activities, then you get a little bit more concerned about a possible stress fracture. So characteristically, you can get two different types of shin splints. I'm not talking about stress fractures right now, but two different types of shin splints. One would be in the front part of your leg here, and one would be on the inside portion of your leg. People who have and the more common one to get is right along your tibia here. People who commonly get those shin splints have flat feet, or they pronate. And why is that? It's because when we go back to that picture here, all right, this is the medial side, and your posterior tibial tendon is the strongest tendon on the inside. If you have a flat foot and you do a lot of running, right into this area here is where that tendon comes from. And it starts to kind of get fatigued or pull on that bone, or you get abnormal strain on the bone into that area, and it gets painful. You get like a periosteitis, or even that sometimes the bone itself can become somewhat irritated. And it usually almost uniformly, when it's medial shin splints, kind of is right along the course of the posterior tibial muscle belly. You can as well get shin splints on the front part of your ankle, and those are usually people who may not have as strong of dorsiflexors, or their calf muscle, their Achilles tendon is so tight that it's taking over for the anterior tibial tendon, which is on the front part of the leg, and the anterior tibial tendon starts to get irritated right into this area, because that's where the anterior tibial tendon comes from, the muscle does. So again, everything is about imbalances, and even this comes to play as well. So lastly, it is important what kind of shoes you wear, especially if you run a marathon. There are different types of shoes for different types of feet, okay? Typically if you have a normal foot, you just need a stability shoe, high arch, something that gives you more cushion because your foot doesn't absorb shock as well. And then if you have a flat foot, you need something called a motion control shoe, which is generally built up more on the inside portion of your foot. Sometimes orthotics can be beneficial. They support your arch. In particular for plantar fasciitis, they take tension off that ligament, the plantar fascia, and they can also control your hind foot motion so that whatever imbalances you may have of those muscles, you can accommodate for them with an orthotic. Quickly, we'll kind of discuss this, and if there's any questions, feel free to answer them. So, this big kind of push, or it's a hot topic right now, this barefoot running, and I put back to the future. Why? Well, when people were first running before they had shoes, this is the way that they ran. But obviously in Western society, we all wear shoes. So the majority of people wear shoes right now if they run. What's interesting though is that when you run without shoes, or even when you run with those minimalistic shoes versus when you run with a typical standard running shoe, you run differently, okay? And has anybody here tried that out yet? Okay. Yeah, you definitely run differently. So after you, and it might not be right off the bat, but after you start running for a little while, you notice that when you run with the minimalistic shoes, or you run barefoot, you land more onto your forefoot, on the front part of your foot. And that's where the perceived benefits are for running barefoot. Your stride length when you run barefoot is shorter, because it's almost like when people run sprints, they run on their toes, so it's similar to that. The stride length is shorter, so you take more steps, but your calf muscle, I guess the biggest real benefit that is kind of seen is that the calf muscle, which is mostly a deforming force when you run with your heel striking the ground, actually becomes a support because it helps your body absorb shock. You land on your toes, and the calf muscle, which is the strongest muscle in your lower leg there, helps to absorb the shock. So you actually, they've done studies, you get less force at the knee and the hip running that way. Now, the jury's still out whether or not there's any, pros or cons, or one of them's better than the other. But I would tell you that there's definitely some benefits of that, and that certain people really swear by that. And you can go online and see they've taken slow motion videos of people running the Boston Marathon, and people running side by side, wearing shoes and running barefoot, and it's interesting to see how they run differently. So typically, when you run, your heel hits the ground. When you run with shoes, and all the force goes up, right up to the leg, because your heel's like this, and then your lower leg is bent behind you, so all the force gets jolted up through the knee up into the hip. When you run barefoot, or if you run in the minimalistic shoes, you land on your toes, and the force goes more straight up, not really, because your knee is bent somewhat, not really up into the knee. It gets absorbed through the muscles more, and there's less strain. That's kind of one of the perceived benefits. So you can, in some of you more avid runners would kind of know that some people have trained themselves to run on their heels with regular shoes, but also to land more on the midfoot with more regular shoes, and then the toe running would be more with barefoot or the minimalistic shoes. And the benefits are kind of what I told you. That's about it. Any questions?
How long should it be before you change orthotics when you have bloody nose like that?
It kind of really depends on, the shell of an orthotic will last for 5 to 10 years depending on how hard you are on it. So as long as it's in good shape, usually it's just the cover over top of it that needs to be replaced. But if you're running a lot, I'd say probably every year to 2 years, you probably should have them replaced. Just for regular wear and tear for someone who doesn't run, it probably lasts over 5 years. Yeah?
I heard you mention anti-inflammatories. What about the topical anti-inflammatories? Do you suggest them before or after?
The question is topical anti-inflammatories. Any particular disorder you're talking about? Achilles. Yeah, I think as long as you understand, especially with Achilles tendon problems, are one of the things that people can run into problems with, because it usually, if you don't get it under control, can get a lot worse, and then that can lead itself to ruptures and things like that. But I think topical anti-inflammatory is okay as long as you're doing everything else. You're doing the stretching exercises, and you're not using it as just a crutch or a Band-Aid. But I think they're okay. They're probably safer because they're not cleared by your system, safer than the oral anti-inflammatories. Maybe not as effective, but
before or after exercise? Or?
You could do both. Yeah, you just have to follow. There's different types of the topical anti-inflammatories. You have to follow the directions. Usually, you have to use them. And most of the ones that I prescribe, you have to use 4 times a day if they're going to work. So.